Good morning, and welcome to Mount Sinai at the Fuso Heart Hospital. We're very happy to have you join us today. You have to forgive the more casual look. It's 100 degrees with 100% humidity outside. But today we have a great case for you. But before we jump right in, I do want to remind everyone that next month we have our New York Endovascular Summit. It's our interdivisional chapter that we have here in New York, including vascular surgery, podiatry, interventional cardiology, interventional radiology, with a very elaborate curriculum discussing not just aortic and venous and podiatry issues, but also with a specific day on September 10th, the day before. The 11th for a dedicated fellows course with obviously a fellows case competition and prizes at the end too. And we're hosting this event once again in New York on September 12th and 13th, and we're all very, very excited to engage in this open discussion. Great live cases from around the world, and we hope to see you there. And we are really excited for another fantastic conference coming up in just a couple weeks now. That being said, today in the lab we have a very unique case, one that I think I can safely say that this case has not been ever been done live before, just because the device being used is not one that has been done live. And we're looking at a very interesting, severe case of carotid stenosis with the plans to use the Neurogard device. So I would like to pass it off to Dr. Krishnan and Dr. Faries, the Dr. Plural Faries, because we have two of them in there today. So guys, please take it away. And just again, so Dr. Faries is our chair of vascular surgery here at Mount Sinai, and we're very lucky to have him here today. So please, guys, take it away.
Thanks again. Thanks, Raman. And, again, we're excited. I do want to say, Raman, that Chris Metzger did the first case, I believe, at the ISET meeting with this. But this is our first case in our hospital live. Obviously, Dr. Faries and I myself have used it in the trial, and it's a different device at the time, and it's completely has evolved. But anyway, let me introduce our team. First and foremost, Dr. Faries is finishing up an emergency. As always, he's the chief of vascular surgery for our system, and he's on the way up. And so he will be here shortly, but I know that everybody's logged on and we want to stay on time. That's why I went ahead and just started with this case. So I want to introduce our team here. To my left, behind me, is Ray Lascano, our interventional nurse practitioner. To my right here is Michael Sola, our endovascular fellow this year. To his right is Christopher Faries, who's what year are you, Chris? Fourth year vascular surgery resident. And then to your right is Ashna. And last name? Riker. And Ashna is a first year. So, and then our team here, as you know, is Reka. We have Mac, and then we have, who else is out there? We have Freddie, and of course, Damien. And so we're very, very grateful to have them all here. So we have a very interesting case. So I'm going to go ahead and have Michael here just start with the presentation. And since I have Christopher here, he can go over the CT with you guys, or we can read it and Chris can make any comments. But go ahead.
Absolutely. Let's dive in. So we have a 73-year-old gentleman who was incidentally found to have a 50% left internal carotid artery stenosis and a 99% right internal carotid artery stenosis during an MRI study. He is completely asymptomatic from this standpoint. He has a usual constellation of symptom, past medical history of hypertension, hyperlipidemia, diabetes, prior CABG, and prior tobacco use of 30 years, quit 20 years ago. He's on aspirin, high-intensity statin, and multiple blood pressure medications.
You have to slow down, right? Yep. Go ahead.
These are the CT scans.
So go ahead. You can just read what you see. So basically, you can see that the arch is a very complicated, probably type 2.5 arch. And then you can see that he has a tight right internal carotid lesion with just moderate calcification. And then the left is again, non-obstructive as for the CT. Yeah. And then let's go. Yep, there's the results. You can read it.
Yep. So the result is atherosclerotic changes in the bilateral internal carotid arteries with severe focal stenosis, the right cervical internal carotid artery, and mild focal stenosis in the cervical left internal carotid artery. So whenever we're thinking about
so wait, let's hold on this. So let's go into this. So I mean, one of the things that we always talk about is asymptomatic carotid artery stenosis, and with the indications that have changed, Raman, as you know, anytime we've done it at Mount Sinai, we've always done it at a very how can you say together, where we have vascular surgery and cardiology look at it together and decide what to do. So in this particular case, you have a high grade, 90+% stenosis, at least by CT, who in a completely asymptomatic patients who is adequately medical managed, and I think that that's kind of the discussion. So Chris, I mean, as a senior resident here, I mean, how do you approach these in your clinic? I mean, and what exactly do you look at? How do you decide whether you're going to treat or not treat an asymptomatic patient?
Yeah, so predominantly if they're asymptomatic patients, you look at the degree of stenosis. Generally for asymptomatic patients, you treat them if there's 70 to 99% stenosis and the life expectancy of greater than 5 years.
Yep, that's a great point. So, and the idea here is that they're asymptomatic. And Raman, as you know, these patients being asymptomatic, especially with CREST, 3 trial going on, looking at max medical therapy, you really have to use a system and a combined approach that's best. So here at Sinai, Dr. Ferries, Peter Ferries, and myself, we look at the angiograms and we decide together. And the criteria that we use is very simple. First, we look at arch tortuosity and tortuosity of the carotid and the safety of really engaging and doing a carotid case, and we do that generally with CT followed by diagnostic angiography. Second thing we look at is obviously anatomically I'm talking. Second thing we look at is any tortuosity of the distal landing zone and any redundancy of the proximal common carotid. So when you have redundancy of the proximal carotid and then you go ahead and advance your sheath, you can obviously push the redundancy and the tortuosity further distal, making it difficult to land the filter. Third is, of course, we'll go ahead and look at the tortuosity of the distal carotid and how difficult it is for an interventional approach. Now, based on those, and then of course last is calcification. Based on all those things, we talk about what are the other approaches. Well, one could be transfemoral. Transradial, we're not really, big fans of it here. We haven't really done a lot, and our experience is not a lot. We have done a few, and could be part of the algorithm, but generally for myself and Dr. Ferries, it's usually not. Number 3 is, of course, TCAR, which again, if any type of hostile anatomy proximally in the aorta, we will go ahead and do a TCAR, which is very, very, a short leash for us. If we think there's any sort of risk, we'll go ahead and very quickly default to TCAR. And of course, at the end, it's, I think we all consider carotid endarterectomy the gold standard, and that's where I leave it up to Dr. Ferries to decide. So maybe I'll ask Chris here when Dr. Ferries is coming. What are the things you look for anatomically for a carotid endarterectomy versus, we would know about transfemoral, but carotid endarterectomy?
Yeah, so if you're deciding between transfemoral and carotid endarterectomy, anatomically specifically, you're really looking at the location of the lesion, the distal and the proximal extent. If the lesion is, very distal, it's up, above the angle of the mandible or anything like that, it's not really surgically accessible from an open surgical standpoint. So in that scenario, you do something either endovascular or hybrid.
Or TCAR, or hybrid, yep.
Yeah, and then the other thing we look at is just the comorbidities of the patient, prior neck radiation, things like that.
Yeah, so again, that brings a very important point to by Dr. Ferries, because when you look at the neck, sometimes you have this short, thick neck, and it looks like, oh yeah, it's a perfect carotid for an endarterectomy, but then surgically, these guys have to go through a lot to get to it, and gals. So I think that, I think that's why this combined approach, Raman, that we've been able to do has really worked out well. So this device, the Neurogard device, which we're gonna go ahead and do the presentation while we wait for Dr. Ferries, is to go ahead and just show some of the differences with this device and why we chose this device in this particular case. So it's just recently been FDA approved. We were part of the trial. The trial results are going to be gone over by Michael. Yeah. Michael?
So as we just said,
before you jump into the device, it's a couple more things I think that maybe we could just touch on before Dr. Ferries gets in, and we can jump into the specifics of the device. But between all of you guys in the room, I think first of all, you guys made really, really important points. At the end of the day, asymptomatic carotid stenosis, the first symptom is unfortunately a stroke or a stroke-like event. It's a little bit different than having like anginal symptoms or something like that. But so it's the first episode is usually, it has the potential to be catastrophic. So I think having so much research in this field and having all these different devices available at our disposal really allows us to take care of these patients in the best way possible. Now, that being said, this patient seems as though they only really had a CTA. Chris, Prakash, what's your go-to study for carotid imaging?
Well,
would you be satisfied with just a CTA? Would you also want some velocities, see diastolic?
Sure. Absolutely,
velocities?
100%. That's a great point, Raman. And unfortunately, in this patient, well, not unfortunately, but fortunate to have the patient sent to us. He's sent from Southern New Jersey, and one of the doctors there, who's a good friend of our lab here, has sent us this patient was an incidental finding. Unfortunately, the ultrasound that we got did not really reveal anything. So Michael and I decided to leave it out. And when we admitted him, we had a CT from the outside, which again was inadequate. So we had the choice in the hospital of either doing a CT or an MR or an ultrasound because of time constraints, and we just decided to get an anatomical diagnosis with the idea that if it was a good thing. But you're absolutely right. Elisa and Chris can tell me whether they do anything different. For us, obviously physical examination, number one. Number two, obviously good history and physical, and number three will be a duplex ultrasound followed by anatomic or axial imaging if we're planning on intervening or doing surgery. Anything different?
No, I mean, predominantly the same. So if we see them in the office or refer to us, generally we'll start with the duplex just because we have that available in the office, and they can give you some good information. See if you have elevated velocities, and importantly also to see if the carotid is patent or if there's any occlusion. Mm-hmm. If it's occluded, obviously you don't want it, and they're asymptomatic, you don't want to treat that. And then as far as CT goes, generally we almost always have one basically before carotid endarterectomy, just because, again, like we discussed earlier, you need to know those anatomic considerations and whether or not it would be accessible and to determine what treatment modality is best.
And it's a lot of people are getting neuro consults. We don't generally, Peter and myself. I mean, we do obviously examine the patient, speak to the patient. We certified to do the Rankin score, so do that stuff. But again, it's not like we get a neurologist to come in and weigh in, or do we get an MRI? I mean, in this, I think it's pretty clear. I mean, you'll see the angiogram. I mean, this needs to be fixed one way or the other. So this kind of leaves out that doubt in terms of whether we should do an intervention or surgery. It doesn't really matter. We just need to get this guy treated. But that's a great point.
I think this case, by this CT angio alone, I mean, I think it's quite clear that this is, meets all available defined criteria to advise for revascularization. That being said, Chris brought up an interesting point, about the CTA on 100% of the patients. Chris, from a surgical perspective, how does a contralateral occlusion affect your decision tree?
Well, if it's occluded contralaterally, you're obviously going to be worried about perfusion to the brain during any clamping or anything like that. So if you have any contralateral occlusion, you're going to need to, for sure, shunt surgically.
And also, Raman, as you know, looking at systolic velocities with contralateral occlusions can be very misleading. And that's why you bring up a great point of diastolic velocities. A lot of time, because of the high flow rates, a lot of people base their carotid criteria on stenosis ultrasonography on systolic, based on the systolic velocity. And you'll have systolic velocities of, say, 290 or 300 with a diastolic velocity of, say, 60 or 30. And so that's also a little misleading. So getting a CT when you have, misleading symptoms or misleading signs might be worth it to look at it beyond just the anatomical, diagnosis. Second thing also is important is that, ultrasound and calcification really is tech dependent. Peter and I have done angios here where, it says no calcium. You go in and fluoroscopically you see the calcium chunk moving and it's a concentric calcium. So, ultrasound and calcium in a good reader, definitely you can have a good thing, but definitely, obviously, the ratios are important, the indices are important, and of course, the plaque morphology is important. Other positive things about ultrasound is you can look at, what type of plaques in the ultrasound, whether you have a lot of, a heavily dense plaque, which, can obstruct a filter and can cause no flow. Also, long lesions are very good to be identified in CT because, again, they're more complex and you can have higher rates of embolic events. So there's a lot of information that I think imaging is important, but I think ultrasound and CT is depending on your availability, your expertise, local expertise, and what communication you have with the team. So this way you can get the right information to start.
Fantastic. That's a great discussion. I think, Mike, it's probably a good time for you to get started.
Good time. Yep.
Great. All right. So as we discussed, it's a big decision tree whether we are going to do TCAR, CEA, or transfemoral carotid artery stenting. In prior recent registry data back in 2022 from Colombo et al. Showed that to this day, from 2016 to 2021, that carotid artery stenting does have higher stroke rates than CEA and TCAR. And this trend continues, and that's just periprocedurally. This trend continues for about a year out. And when we separate asymptomatic and symptomatic patients, this trend continues. However, also back in 2022, White et al. Published in JACC a great paper summarizing a lot of the trials and the trajectory of the stroke rates in both CEA and carotid stenting. And during this time period, the rate of stroke have decreased significantly. And that's both for CEA and stenting. Importantly, though, that stenting continues to have a higher stroke rate than CEA. Now, we can say, why are the stroke rates improving? The facilities can improve overall, as well as the technology can improve for stenting. That's what
and
we
also
want.
the operator expertise.
Absolutely.
And the operator experience. And I think creation of carotid teams and more discussion among specialties have also helped.
Absolutely. So the Performance 2 trial recently came out, and that's detailing the Neurogard carotid system that we'll be displaying today. It's a 3-in-1 system looking at a 40-micron pore embolic protection filter, a nitinol stent, and a post-dilation balloon, all in one system. This study in particular looked at high-risk anatomic features as well as high-risk comorbid features for this patient population, suggesting that these patients may not have been surgical candidates. This device is deployed on an already placed embolic protection device. Their device is the secondary filter is deployed, which is 40 microns, and following the deployment of the filter, the self-expanding stent, nitinol stent, comes out, followed by expansion of the post-dilation balloon. The post-dilation balloon, as well as the secondary stent, come out in tandem, and the primary embolic protection filter stays in place. The Performance 2 trial showed great outcomes for this patient population of about 305, showed 30-day and 12-month outcomes of very low stroke rates. And one of the reasons for that is the secondary filter that they were using is 40 microns compared to a lot of the other filters are anywhere between 100 and 200 microns, so it's able to capture smaller debris and particles, as well as it's a secondary filter in the system, allowing improved dramatic decrease in stroke.
So a great presentation. But I think the idea here is also to understand that one of the reasons, I know Dr. Ferris is here, so he'll make some comments as well. One of the differences with this particular device is that you have the ability to limit your exchanges. So one of the things you got to understand as carotid people who do carotid stenting is that every time you manipulate, every time you change, you exchange, there's a chance of clot formation, embolization, disruption of plaque, dissection, all these things are there. So the nice thing about this device is when you go up and you go ahead and you have distal protection, you cross the lesion, you do step 1, deploy the filter, step 2, deploy the stent, step 3, post-dilate, and you're done. So the natural part is it can be done with proximal protection or distal protection, depending on the anatomy. Obviously, in the trial, it was done with using a distal protection with a filter distally. But obviously, we've done some cases or with having the proximal protection with this particular device, which I guess it's kind of off-label in terms that it's not involved in the study. The other part also I think is important to remember is that the pre-dilatation is allowed in this particular device. You can pre-dilate if you need to with the current or the previously deployed filter, which in this case will be an EmboShield, and then we'll go ahead and do the work that way. So as Dr. Ferris is getting ready, I'm just going to go ahead and start doing the device. So Dr. Ferris, a little quick update. We went over the performance trial. We made some comments on patient selection for carotid endarterectomy versus stenting based on calcification, and then we're just going to go over the device.
Yeah, a great plan, and my apologies. I just had to attend Dr. Rao's presentation at our departmental conference.
Oh, okay.
Probably a patient you're familiar with.
All right, so we've got, so this is the Neurogard system, And I want all of you to see this. So right here is the is the edge of the system here with a stylet. And so what we're going to do is we're going to go ahead and prepare this.
Sleeve.
And how we're going to prepare this is the first thing is you can see here it comes with 2 syringes, syringe A, syringe B, which we're going to go ahead and use it to flush. We've got a wheel here in the proximal area, which is a wheel that is going to both deploy the filter and capture the filter. And then we have a turning wheel here on the bottom, which is going to allow us to deploy the stent and then obviously be able to do it.
With the safety.
With the safety. The safety has to be removed when you're up in the body. And then over here, you've got the flush port, not the flush port, the balloon port, which you're going to prep with standard way of prepping the balloon. So it comes with a stylet here. So what we're going to do is we're going to go ahead and remove the system first. And then I'm just going to have Ray or Dr. Ferries go ahead and just hold it at the end.
Got it.
And then what I'm going to do is I'm going to go ahead and put it in. I'm going to remove the stylet. Okay, and give that to Ray. And now I'm going to put it in water. And I don't know if you can see it, guys. Well, as best you can. I guess you're going to have to do what you can here. There you go.
Nice.
So, okay. So over here, so you have the system. And Dr. Ferries is now going to go counterclockwise to go ahead and open the filter. And you'll see the filter will start to open. As it opens, it'll bend. And the reason it bends like that, you see that, is that there's no wire inside it. So at this stage, I'm going to use syringe A, if I'm right, guys. Am I right here? Syringe A, to go ahead and de-air the system. Okay. And then I'm going to go ahead and push any of the stuff out of it, just get all the air out of it. And then I'm going to have Dr. Ferries re-roll it back and capture it.
And did we go over the pore size on the?
Not yet. Oh, yeah, we did. He did. He mentioned the pore size. Maybe you can comment on that while we do this.
It's just much smaller than 40 microns is a very small opening. So it's going to capture a lot more of the small debris, which is the predominant debris that's generated during angioplasty and stenting.
Right. So now we're going to hold the system straight. And then as Dr. Ferries holds the system, I'm going to sheath the filter underwater. Am I doing it there? Is it going right? I don't see it. Nope, it's not moving. Okay, try hold that down for me. Yeah, let's see now. No, it is.
Getting there.
There it is. Very tight, but it's good. There it is. Now, once we marry the yellow and the black is good, right? Perfect. So now it's sheathed. Now we're going to take it out. Now the filter is de-aired, and now we're going to prep the flush port, which is going to be the monorail port. You got it there, Pete?
Yep, coming out right there. You can see it.
Perfect. Now we're completely prepped with the filter system, and I'm just going to go ahead and get everything ready. So, Dr. Ferries, we haven't not gone up because we wanted to show the prep of this filter, and then Ray is going to prep the balloon traditionally. Okay.
As he has been for years.
As he has been for years. So I'm going to show what angiogram we didn't take the sheath up yet. I just want to show the angiogram. Since we have a CT, we just did an aortogram here, and you can see here the aortogram shows a complex arch.
Please share the arch. There it is.
And Ray, once you get this. So we're going to engage. We're going to get the sheath ready. Wire up. So again, I'm playing the arch again for you. Do you see it, Raman? And you can see that it's a very complex arch. The good advantage, this is what I was telling Raman earlier today, that the advantage of this is that obviously it's got a long innominate, which is going to help us to be able to engage better and be able to track the sheath up. So Galileo 45, please. Thank you. So I normally we would go live with everything there, but given this system that we wanted to demonstrate, we were so I chose a JB1 catheter because of the nose, and you can see how it just popped in there. So now I'm just going to go and get my sheath, my JB1 catheter into the carotid.
And so far, what has been given for anticoagulation?
Heparin alone, as we always do, and the heparin is how many?
ACT right now?
ACT right now is 3 something. Can I have a glide wire, guys? a soft angle glide. Okay. So now what we're going to do is, as we follow our protocol here, is just do a roadmap to get into the external carotid. So Ray, let's take a photo for Dr. Ferris here. ACT is 314, Raman, on heparin. Come forward. I want Dr.
You want to go SVG-RCA for the
Yeah.
right?
Yeah, we just want to take one shot here. Sir, we're going to ask you to just hold your breath like we did before. All right. All right, sir, just hold your breath for me. Okay. Okay, it's all saline. There it is. We'll do one more time. Okay. Okay. Breathe normally, sir.
Big common.
Big common, and you know,
Yeah.
and I mean, there's one of the area, and I want to show Dr. Ferris the prior picture that showed us the landing zone. So this is the prior picture here. Breathe normal, so breathe. Yeah. So that's
Yeah, I mean, it's obviously a long lesion, but also, you know, we typically would like to extend into the common carotid with the proximal end of the stent, just to facilitate filter retrieval, et cetera, and get a better apposition. You can leave the stent entirely in the internal. It's just it might be a little harder to, you know, precisely position it. So, I mean, I think a longer stent is probably going to be
roadmap, brother. So we have the longest stent right now. What is our stent size?
940, I think.
940. Okay. All right. So we'll just give us the glide wire. We'll just go right up. So Peter, I know that proximal protection is something we discussed. When do you use proximal protection with any device? When do you use a combination of proximal with distal? You know, or do you do that in all the cases? And what's your algorithm for that?
You know, I think the advantage of proximal protection for this device is you're going to have the filter that's contained within the Neurogard in position and deployed, but it obviates the need for a more distal filter. In this case, I think you have ample room in the internal carotid artery distal to the stenosis to allow placement of two filters, but you know, sometimes it's a shorter segment or it may have some tortuosity in it and it may limit the capacity to do that. So certainly adding proximal protection under those circumstances is going to facilitate just placement of the Neurogard stent.
I'm just going to take my catheter up a little more here.
So, so outside of the Neurogard device, Peter, you'll see that you'll end up, routinely assessing the mid and distal ICA to decide your filter. But do you ever choose between different filter types, or is it always EmboShield for you? How do you go about deciding which filter you would end up using?
Yeah, I mean, I think that's a good question. I think if it's going to be distal embolic protection, then we typically use a NAV6 filter for that.
Don't move.
Hold nice and still, sir.
Don't move, sir.
But in symptomatic lesions in older patients, octogenarians, you really want to consider proximal protection as well because
far up and over?
it seems.
Yeah.
I think so.
Yep.
It seems to provide a higher degree of embolic protection for those sort of high-risk patients. So those are the ones where we really consider using proximal protection, whether it's MoMA or some other alternative.
So as we all do here, I mean, generally Peter and I go with the Amplats with the 3 centimeter soft tip here, and that's what we're going to do off-road medullary. So it's around K is the lesion. And you remember using the LeMaitre is going to help you as well. So you have the glow tape here to tell you that you're on K. There's some iliac tortuosity, so I use a longer sheath to go ahead and engage. And again, because of that type 3 arch, as we go up, you have to watch the tip of the catheter to make sure it doesn't drop down here or go forward. And if it goes forward, then at least you're through that arch. There you go.
There you come along.
Okay, all right, we're trucking along here.
Yeah, so tracked very nicely.
All right, so we're going to go ahead and just walk this out. I'm going to hold the sheet for Dr. Ferris as he helps me here. And the beauty is, Peter, maybe we can talk about our combination and how we've been able to develop a camaraderie and, more importantly, a patient-focused center to to really help with our outcomes in carotid stenting?
Well, I just think that if you have the perspective of two disciplines that are familiar with, I got you here.
Thank you, brother.
Are familiar with the advantages of different approaches to revascularization, or even maximal optimal medical therapy in appropriately selected patients. I think that's going to be an advantage with respect to treating the patients with the most appropriate modality. And when you do that, you really get the best results. Obviously, I mean, you want to tailor the therapy to the patient's individual presentation. So I think that's really, in our instance, really enabled us to give these patients the best approach to their management. And it also has been a important collaboration with respect to the clinical trials that we participated in and our involvement from that standpoint as well.
So Peter, Christopher went over beautifully, what are the anatomic criteria that he looks for endarterectomy, so on and so forth. But how do you, being someone who does everything, you do endarterectomy, you do obviously TCAR, you do transfemoral stenting. When a case like this, I mean, what can you tell our audience? How do you choose what you want to do on these cases?
So I think that this patient's stenosis is not particularly calcified. So, for stenting, calcification really still is a significant limitation. It's very hard to get expansion of the balloon, full expansion of the stent. You get a lot of recoil, and there are cases of rupture associated with heavily calcified lesions. So I think no calcium present here.
I'll cut the wire now.
I got you.
Yep.
Makes stenting a viable alternative, whether it be transfemoral stenting or transcarotid stenting.
So when you decide to stent, how do you choose between transfemoral and TCAR?
So I think TCAR is, when you have access issues, TCAR is really going to be your preferred method. So, if this severe iliac occlusive disease, bad femoral access, some people will preferentially use, not experts such as yourself, but people who have a little more concern navigating a type 3 arch will use that as a potential
and I think it's the right thing to do. Personally,
yeah.
I totally, and we do very few type 3 arches. This is probably one of the few we've done. We generally would send to TCAR with that nice anatomy that we have for it. But I think in this case,
if the patient can't tolerate usually we do TCAR with general anesthesia as opposed to just local anesthesia for the transfemoral. And so, if there are pulmonary issues or significant cardiac issues, then I think transfemoral is going to be preferred over TCAR.
Right, DSA.
But TCAR is very well tolerated, so it's certainly an alternative to consider.
Peter, can you talk a little bit about the recovery process? Because a big concern that all the patients have is, I go in for my carotid angiogram, and if you stent me, I'll be out by the next morning. But tell me you're going to do a surgery. What's the typical expected downtime in hospital admission you typically keep your patients for each a CEA or a TCAR, and what about the recovery process?
Yeah, I mean, I think it's both endarterectomy and transcarotid stenting, while they're typically done with general anesthesia, have a pretty brisk recovery. I mean, those patients are more than 90% of them discharged. The first postoperative morning, it's in general well tolerated. So from a recovery standpoint, it's really pretty good. It's obviously not as quick a recovery as percutaneous transfemoral access, obviously, but as far as surgical intervention is concerned, it is pretty well tolerated. So I don't think that's a big limitation in terms of patient recovery.
Do you find that it's sorry, go on.
Yeah, well, I mean, if you look at the CREST trial, there was still a higher incidence of myocardial infarction for endarterectomy, even in patients that weren't considered high risk for MI. So it does, from a physiologic standpoint, it's going to be, more of a physiologic stress for the patient. So from that standpoint, that is, I think, a consideration.
Yeah. Have you been able to do any TCARs in select patients with anesthesia that's not general? Have you been able to do like nerve blocks or?
It's not, it's not great. Some people do cervical block for endarterectomy, but the distribution of the nerves doesn't really allow itself for the incision at the base of the neck, really just in the supraclavicular region. So when you do non-general anesthesia for those patients, it's really done with just local, but people certainly have done that. Early on, it was probably 30-40% of patients were treated that way with local anesthesia. More recent experience nationwide shows it's about 10% of patients that are treated that way. So it certainly can be done, but it still involves an incision and whatever physiologic stress is associated with that. So it's not clear that and as far as endarterectomy data, there's no difference in those outcomes, whether it's regional cervical block or general anesthesia that's utilized. So I do think for, patients you would consider physiologically high risk, transfemoral stenting really should still be the preferred approach.
Outstanding. So right now, as soon as we were going up with an Embo shield with the barrel wire.
Yeah, we're just going to go wire this with the Embo shield, and I don't know why my wire is not advancing here. Let me try to advance the wire here.
That's how old school we are. We still call it Embo shield.
Wow, why is the wire not advancing?
Here, let me give you the torque vice one.
But look, it's not. See, when I push it, it's not advancing.
Who prepped this
filter?
Take it all out.
For some reason, it's not advancing. We're going to check what's happening here. To decide.
Yeah, the wire should move independent. Oh yeah, look at that.
Look at that, it's jammed.
Yeah, the wire should move. Yeah, let's just get another one.
Oh, actually, that's better. Okay. Let's try.
Yeah, is it going to move when we need it to? Yeah.
Let's try. We'll try pushing it forward.
Yeah.
No, it's not moving. Get another one.
Yeah, let's just.
It's not worth it.
I must just be wedged in there or something. So.
Now, when the Neurogard device has a filter that has smaller micron pores than the NAV6,
pressure, guys,
right?
pressure
so
here on my sheet
versus 120. So that being considering that you have a filter that has smaller pore size, what's the utility of having a more distal embolic protection device that is more porous?
Yeah, that is a good question, and I think something that we're going to need to determine as we gain clinical experience in the sort of post-market environment. One advantage is, you'll have the filter up before you start trying to advance the whole system with the balloon and the stent into the, a highly stenotic lesion. So you'll already have some component of embolic protection. The reason we use it, the reason it's on the instructions for use and that we use it as a routine is that's how the clinical trials were run, and it's sort of a dual. The philosophy is to have a dual distal filter protection. I think they are looking at an analysis of the distal filters to see if there really was any significant amount of debris captured in those distal filters, and I think that's worth investigating. But that's sort of our default protocol for use for the time being. Either have a distal filter or use proximal protection with the 3-in-1 Neuroguard filter.
Yeah, because it almost seems as if it would make more sense to have the more porous of the two filters be more proximal, so that the
I follow you on that. That is sort of a sensible approach, no question.
Yeah. Unfortunately, I wasn't on the engineering committee to voice my opinion.
We'll get them in touch with you. Yeah, exactly. No, I mean, I think that, you know, there's obviously going to be some opportunities for modification of the overall approach and potentially varying the size of the post-dilatation balloon. And the stent sizes themselves, I think, there's a good variety and sort of appropriate configurations. So I think that's another potential advantage of this system.
And also, Pete, the stent is also quite impressive because it's both an open and it's got the flexibility of an open cell stent, and yet it has the closed cell design, which I really like. I really like it a lot.
Yeah, no, I think that is a nice advantage. And you know, there hasn't been that much advance in sort of carotid stent technology.
Calcified plaque there.
You know, in the last decade or so, and so this I think represents this and the I think you're still in the intro. This and the mesh covered stents do represent real potential advances in the treatments.
Why is he moving, guys? Is he okay?
Now, this device also has a integrated post-dilatation balloon. Prior to this, Peter,
guys.
How often would you be post-dilating all of your stents, even with the distal embolic protection device of your choice?
Yeah, that has really evolved in the last couple of decades, frankly. But we very infrequently post-dilate in a typical transfemoral lesion. Our protocol, our routine has been to pre-dilate with a pretty substantial pre-dilatation balloon, normally a 4 millimeter diameter coronary balloon, and then deploy a closed cell stent. And the frequency where we see a residual stenosis that's more than 10 or 20% is negligible. So in a typical non-calcified lesion, we post-dilate less than 10% of the time.
Yeah, Peter and I always joke that Dr. Sharma, who's our institute director here, senior Dr. Sharma, he'll come in and he'll be like, "Oh, you should post-dilate this." I think that's a good spot right there, Pete.
Perfect.
So he'll come in and say, "Oh, you should post-dilate this," and Peter and I'll be like, "No, it looks great." He's like, "No, it looks bad," and we always tell him that, Dr. Sharma, it's not the same patencies. And so, Peter, in terms of patencies, is there anything that you can tell us about the patencies of the device with post-dilatation versus not? Is there a residual stenosis that's a predictor of restenosis?
So we may want to just redose the heparin.
1,500, please.
It's remarkable how low the restenosis rate is for carotid stenting and for carotid endarterectomy compared to the other vascular beds that we treat.
Maybe I'll
and so, I got this. So it's under 5%. In the CREST trial, it was under 5% restenosis rates and the need for target lesion revascularization. It's probably less than that, frankly. That impetus to gain maximal sort of luminal gain is really not there for this procedure. And, again, as we always emphasize, we're not treating, well, you can discard this. We're not treating, you can throw that out.
Can I get a towel, guys?
We're not treating, a reduction in flow or a pressure gradient across the lesion. We're just treating the embolic potential of the lesion. And so, that's going to remodel once the stent is in place, regardless of
do we need to pre-dilate, you think? What's your thoughts?
I don't think so.
I agree.
I don't think so.
Yeah. So we're going to go directly with the Neurogard system. We're going to see, they call it Neurogard, right? It is Neurogard. We're going to go with the Neurogard system.
We're allowed. It's commercially released now. We're allowed to call it.
We're allowed to call it that?
Yeah.
Okay.
And just remind me if I did read this correctly, right? So Medtronic has acquired the exclusive rights for distribution of this device through Contigo. Is that right?
Yes, it is. It is true. Medtronic has. Let's do a roadmap, Ray. Medtronic has acquired it, but the nice part is it's a distribution agreement, and then Medtronic is really getting it out there that the advantages of this particular device, so on and so forth. So I think it's a good thing that we're able to have this distribution agreement, because Contigo is a great company, but a small company, and probably wouldn't have the reach that Medtronic does.
Mm.
Okay, that's nice.
Right. So now we're going to go in with the device.
Yep, I got the wire.
Yes, sir. So you can see the filter where it is. Now you're going to see the second filter and the device. And when Dr. Ferry is going to walk through the actual deployment of it.
So can we talk about, as the device is going up, how much distance do we need from the more distal embolic protection device and the distal edge of the Neurogard device?
Yeah, and we're going to need to look at the specific radiopaque markings on the device. I think it's 4 centimeters that you need. I'd have to confirm that. You have wire?
Yep, I do. I'm watching it just track across.
So here we come. The device is coming into position. First, you have the filter. So that's the distal
Let's come
aspect.
off roadmap now. So we know it's around A is the lesion.
And then you see the stent starting.
So let's go a little bit.
So there's a transition. I don't know if we can highlight that, but the distal filter is the sort of first radiopaque structure that we see, and then you see the stent itself starting, where that additional marker is basically, and you can see the stent extending down, really to the to the level of the sheath right now. So we are going to have to go in a little bit.
That's exactly what I was thinking, because I was trying to stay away from that filter, but we're going to have to go in a little bit more. I think right about there.
No, once the filter is the distance between the embolic protection device dedicated on the device, that distance between that and the stent, is that fixed or can that be adjusted?
Yeah, that's fixed.
That's fixed.
It's shorter than it was during the clinical trial, but it is fixed. It can't.
So I think we should deploy the filter here, Pete. What do you think?
Yeah, I think it looks good.
I think it looks good.
You want to take a quick picture, just make sure our stent's where we want it to be?
We can inject around. We'll take a quick shot here. Ready? Don't pull back, just inject. There you go.
In some more.
You see how close you are to the distal filter? I think this is pretty good, Roman, don't you think?
Just because the proximal edge of the stent seems a little close.
It looks like
a
little bit. Yeah,
agreed.
just
slightly a little bit more. Right about there. Let's take another shot here, Ray.
Yeah, I like that.
Much better.
And you can get a good look now at the stent as well.
Mm-hmm.
The distalmost.
I think, Peter, your mic is off.
Oh, Dr. Ferry's mic is off, so let me just talk. So what Dr. Ferry is saying, the distalmost structure that you can visualize is the filter that's sheathed, that has a sheath on it right now. There's one marker, the second marker, and the third marker you see is the beginning of the stent, and then the stent ends right below the bifurcation, and then you could see the balloon is in trial. So let's unsheath the stent here to keep going. You gave some ACT, right? So Dr. Ferry, you're going to go counterclockwise, right?
So we're just keeping a look at this, and we should be seeing the sheath coming back. There we go. Yep.
And a little bit of movement of the entire system with this. It seems as though your stent has come down a little bit.
We'll give a little bit more dye. Is it unsheathing?
I don't see
the lock. The lock.
Yeah, but that's for the
that's
stent.
for this. Yeah. You have to roll it first. Yep, roll it 2 centimeters to bring the two sheets together. Yep. Keep coming.
Yeah, that's it.
That's it. Now it's coming. Yeah.
No, it's not moving anymore.
Oh.
See, it doesn't look like it's unsheathing.
No, but you have to roll the sheet down first. The sheet is on top of it, so you roll this down, right? So what you want to do is, see, right there.
Yeah. Yeah, that's supposed to.
I think it's.
Is your filter deploy?
The filter did not deploy because.
I think it's still inside that sheath there.
Yeah, I'm just trying to recapture the filter here. Let me do that. Okay, now let me try this.
Yeah, but that's the deploy of the stent.
Let's try now.
Yeah, so that sheath should be coming down, right?
Yeah, the sheet's not coming down, guys. There it is. Okay, now it's coming down. No? Yeah, no, not quite.
I don't think so. You can step on the right pedal and take a look, but I don't see it moving.
Yeah.
I don't see the filter open.
Okay, give me a regular. Let's do a regular.
Just step on this one.
Yep, no, this one already. I think it's this one, the middle one. Ready? Yeah. Nope, the filter did not deploy there. So I think what we're going to do. What do you suggest? Yep, it's all the way to the right. Okay, we'll try again.
Yeah, I think maybe just use it. Yeah, but that's the.
Filters to the right. Now the dial is not coming down though.
You know what, let me hold this and you hold that, but we'll see. But all right, you ready?
Mm-hmm.
There we go.
There you
Now
go.
we
It's
have
not
some
it's
movement.
So
All right.
now,
all right. Little technical difficulty
so why don't
here.
we just confirm our
Yep, I'm going to
position
just
real
do
quick?
Succinate. Nope, a little Succinate.
Yeah, but I mean relative to the stenosis.
You got to go up with the system then. DSA? The stent system has come down a little bit.
Yeah, let's just do a quick DSA and
Mhm.
reconfirm.
Yeah, stent has, oh, it's pretty good.
It's not bad.
It's actually not
still
bad.
difficult. All right, so I'm gonna if,
No, you
any,
need
if
to-
we if it
you-
migrates in a few millimeters, we'll be okay.
Yeah.
So we're gonna keep coming down because sometimes it does that. We'll keep coming down. All right, so we're unsheathing.
Now we're unsheathing the filter. You can see that, guys. Good. Now stop there, right there. So now you see the markers are aligned. The filter markers there. The second marker by the P are aligned. That means you're right on top of the stent. Now we're going to take a quick picture. Ready, Ray? Yeah. No, we're going to take a quick picture.
Yeah.
That's
Hold
fine.
still, sir.
All right, deploy the filter.
right,
So we're going to
filters-
deploy the filter now.
So we're opening up the filter.
And there's the
There we
filter.
go.
There you
Okay,
go.
yeah. Now we can
All
see
right.
that well.
Now
okay.
we're going to take a picture. Sir, don't move. Okay, perfect.
Good.
Okay.
Yeah, it looks nice.
We like
All
that a
right.
lot.
Very strong, Ray.
Now we're going to go ahead and deploy the stent. Let me do a little test, Ray. Okay,
That's a little higher than we
little
really
negative
want. Yeah.
A little negative. Mm-hmm.
You want to try to come down just
Yep.
a bit?
Mm-hmm.
If it doesn't move, then we'll just deploy here because I think it's going to be in the internal.
Yeah, it looks like it's going to
Try
land
now.
in the,
All right, so we're
the
gonna.
proximal internal. And what's the size of the stent here?
Okay. All right, good.
Not
got it.
40.
It's a
is it?
9 by 40, but
All right.
okay. I think we're deployed.
All right. So now we're going to have to recapture the balloon. We got a balloon first.
Do we have the insufflator?
So we have a question from the audience asking about, are we temporary pacing for bradycardia? Yeah, I can just kind of go ahead with that. You know, routinely for those watching, temporary pacing is not
Shutter in, Ray.
a part of our typical algorithm.
I think we need to.
We can give
bring this one
glycopyrrolate.
I can. Let me try.
We can, you know,
Let me-
to
I'm
kind
gonna
of
inflate
counteract
first.
some of the pressures, the
Might
human
be able to
dynamic
get all the way
changes
back out again.
with the baroreceptor reflex. So again, typically the first response is not to go ahead with a TVP, but rather begin with just medical management of the problem. The greater issue we see is quite often is hypotension, in which case we'll give medications to bring up the blood pressure. This will then also require, you know, sometimes an ICU stay to make sure that the pressures
just
are
go ahead.
above
Touch up
the
the
usual
proximal.
Come back a little bit.
systolic
There you go.
upper threshold. Yeah. And why not radial access? I mean, so again, at our institution, you know, we don't typically go via the radial approach. I think there are a few anatomical considerations, namely this one, to go from a radial approaches will be, you know, quite challenging given the anatomy. I think it's
Put
just
it on
comes
corner,
down to
Ray.
center experience and what our exposure is to the to that access modality. Transfemoral has been our
Shutter in.
predominant approach.
No,
And
you don't need dye.
you know, until I think the technology
I
can
think
help
we need to
can
fully
calm down a little bit.
navigate
Yeah.
this complex anatomy, I think we're
Okay, now.
we're going to be
up
sticking with the
for
transfemoral approach. And obviously, when we have more dedicated reasons to choose a radial approach, we'll make sure we go down that route. If the transfemoral is not an option, or the TCAR is not an option, or CEA is not an option. So just to resume, so the stent has been pulse dilated,
Yep.
and
Now I'm going to capture the filter.
I've seen 3 balloon inflations, which is
Which is
more
very
than
rare.
which is more than I think we've ever done collectively.
So the
on
balloon's
different
back.
cases.
Now I'm just going to take the whole system out.
Now the system is not captured at all; it's just pulled out.
It just pulls out once the balloon comes out.
Wow. Okay.
Okay, ready? I'm going to fix my sheet.
Yeah. The filter, so it's interesting to see that the initial filter of ours has been pushed up quite high during this entire process. I mean, again, this has been a so now this is just the our device being pulled back now. Okay.
Yep. So what we did was we walked it back. Remember, you have the dual filter protection. The stroke risk is the lowest ever reported with transfemoral stenting. And obviously, every device, like has its merits, and this has a very good merit because it has two filters you can use, and you have very good protection, very trackable through this lesion. So I'm just going to go ahead and bleed back here. We're going to check our pressure, and go ahead, Ray. I got it. So what I'm going to do now is just take a picture, and then we'll decide on how it looks. A little bit of air in the system, which you would expect. Let's see here. Just going to bleed back. Okay. DSA, Ray? Yeah. Sir, hold your breath. Okay.
And beautifully positioned in the internal as we had planned.
And so it's actually, with a little bit of issues that we had with this device, trying to understand it, you can see that we have a beautiful result. The stent is very well deployed. The filter is not full. We'll check this filter now. And in the meantime, I'm just going to, if Peter's okay with it, I'll capture the filter.
Yep, I think it's time.
What's the change in the hemodynamics?
Show the hemodynamics, guys.
Huge change in the.
It's been nice and stable from a heart rate standpoint, and the glycopyrrolate I think really is very good for blunting that vagal response that you see.
Yeah. I'm glad we saw the challenges. One of the things is also understanding that, that sheath, the movement of the sheath to me is something you got it is something that has to be watched under fluoro. I know that a lot of people have done it without, but I think looking at it today, maybe it was the tortuosity of the arch that also gave us a little difficulty in actually doing that. So I think regardless, we were able to manage. We were able to deploy without incidents, and it looks like the result is beautiful. Don't move,
Hold still, sir. Hold nice and still.
So again, let's see this
We'll watch the proximal edge, and then obviously we want to watch
this area here.
The stent.
Yeah. Okay, let's turn his neck the other way, guys.
Let me send the sheath up a little higher.
That's what I'm going to do now. Okay. Oh no, that's a little too much. That's actually good right there. Okay, one more time.
So we're just altering the wire bias a little bit here by sending the sheath up. We're still getting caught on a couple of the stent struts coming around that tortuosity. Yeah, we got
turn the other way, guys.
We got further on that one.
Take like a.
So we're just trying to alter the shape of the. Oh, you're right there. The shape of the carotid vessel so that it tracks a little more easily.
Just to answer some more of the questions in the chat. Yes, this is a self-expanding stent. Does Peter, for the Neurogard device, do you know what the stent lengths available are? Are they all 40, 60s?
Hold on a second. Let's see. It looks like it came down a little bit. I'm sorry, Raman. We're just looking at Dr. Ferris. He just pulled the filter down slightly. Oh, came back a lot now. Yeah. So let's see now. Yeah, this is some of the common challenges you can have with this. We're obviously there. See how we took the sheath in and then into the stent, and then we're able to pull it out that way. So let me get a 20 cc syringe, Ray. So one of the things we do is we go ahead and use a 20 cc syringe to bleed back. So we're going to go ahead and withdraw. This is a 50. We're not going to take 50 cc's of blood, but we're never going to take at least 20. And this is a practice that Peter and I have done since we started. I'm sure Peter was doing it before he met me.
Let's back this sheath out just a little.
Absolutely. Yep. Right there. Okay. So we're going to go ahead now and All right, sir, we're going to hold your breath. Oops, look what's happening here, Ray. What's happening here?
But Raman, to your point, if you're using proximal protection here, you don't have to worry about trying to retrieve that second filter. So that's kind of the downside to proximal protection is that the access has got to be, 9 French basically. So, if your femoral access is a concern, and you're obviously not going to go transradial with a 9 French system. So that's a limitation, but it does, allow you to work just over a standard coronary wire.
All right, DSA.
And then you don't have to retrieve that additional distal filter.
Hold your breath, sir.
You see a little spasm from where we were moving the filter in and out, but I think it looks pretty good overall. I think that's going to resolve. We usually don't treat that with nitro unless it's really flow limiting.
I'm just going to do the brain shots for us. Make sure we leave them with what we came with. Low mag here, right? Oh, lower mag. All right. Oops. Okay.
That's good. And now he's neurologically intact following commands, but we like to just visualize the cerebral vessels to ensure there's no indication of embolization.
A little bit of crossover now, too.
Yeah. Well, I think that was a very high-grade stenosis, and you saw that on the CT scan as well.
So there's a question again from the audience, and we'll probably use this as we begin to wrap up, if we take our final pictures, but regarding whether or not there was a proximal lesion that was missed. But I'll just say, if you look at the angiogram, there's a little nugget, but that's more proximal, closer to the actual bulb and the bifurcation. That's most certainly not flow limiting nor contributing to the major stenosis in this case. So leaving that alone, I think, is a perfectly reasonable and at times advisable, considering that's not really where the disease is. Again, the original plan was to
breathe normally.
Yeah, I think so. We don't want to
breathe.
Treat more of the length of the vessel than is needed. Again, the risk of restenosis is very low. So, if you want to go another centimeter in terms of treatment, if you're going to use a 4-centimeter stent instead of a 3-centimeter stent, it doesn't affect the restenosis rate. So it's reasonable to do that. I don't know that applies to placing 2 stents. But as far as the embolic potential, I think that irregularity in the lumen right at the bifurcation,
breathe normally,
proximal most internal carotid, really has very, very limited embolic potential. So I don't think it needs to be stented with respect to stroke prevention.
So let me just show the picture to those people who've asked, and I think it's a good question. I think clearly, there is a nugget, like Raman described it. But I think, when you look at the picture, I don't think it's at all obstructive in any way. Yeah. So I agree with it. See, you can see it there, and then you'll see it over here too, I think, right here. Yeah, let me see. See it right there. You see the little outpouching? That's the same thing that's accentuated now because you have now gone ahead and stented it. And now with the stent, I think now with a normal lumen distal, it tends to kind of hit your eyes a little bit better.
Yeah. But again, I don't think that there's any increase in velocities because of that little tiny itty-bitty guy there,
But I mean,
I think the majority
really
of the disease,
No.
Yeah. The real lesion was, I think, hit appropriately with our stent. Yeah, this is a great case, guys. It's a great demonstration of the Neurogard device.
Yeah, I think we should talk a little bit about anticoagulation, antiplatelet therapy. What's your Dr. Ferry's microphone is gone again. Anticoagulation and antiplatelet therapy. What are your thoughts on anticoagulation and antiplatelet therapy, Dr. Ferris? Can you hear it?
I agree with you. I mean, we routinely just use heparin and monitor the activated clotting time when we're intraprocedural. For these patients, it's really dual antiplatelet therapy is the standard for carotid stent patients, and that's what's been utilized in all the clinical trials. we don't routinely test for Plavix resistance. We don't routinely run PRUs, but some labs do. And then, you can switch over to Brilinta, obviously, at that point as appropriate. But I think that they all need to be on dual antiplatelet therapy. And if they can't be, and for this stent, I think 1 month duration is adequate. For those mesh-covered stents that are being evaluated now, it really needs to be a longer period of time. So that can be a consideration if they can't tolerate 3 months or 6 months of dual antiplatelet therapy due to risk of bleeding at some other site.
And then surveillance, Peter. I mean, what we normally do is the usual surveillance protocol. Do you do anything different?
No, I think what we've sort of evolved with carotids. We used to assess them every 3 months for the first year, but the incidence of restenosis is so diminishingly low that we've gone over to getting one duplex baseline immediately, within a month of the initial procedure, and then 6 months, and then 12 months, and then annually. If there are no, changes, increases in velocity. The thing you have to watch for with stenting is stenting will alter the internal carotid itself, and so you will see increased velocities that don't correspond to significant stenosis. So it's good, if you're seeing a change from baseline, that's the most important thing to follow. But even when we've seen it even when there are really significant increases in velocity, presumably due to the compliance change in the internal carotid, we still will get a CT scan to assess it, because usually it's not a significant stenosis, even with a highly increased velocity. But occasionally, on a 1 in 100 maybe, you may actually see a significant restenotic lesion.
Absolutely. Okay. Again, Raman, I think 9/5. I think that, for everybody at home, Dr. Ferries obviously is going to run the carotid session at NYEVS. There's a learning, therapy-based learning course that's run by Medtronic. Dr. Ferries and Dr. John George are leading it. That's on Thursday. So if you guys are interested, go to nyevs.org, where everything you want to know about this particular device and all about carotids will be discussed by 2 experts in the field, Dr. Ferries and Dr. George. Then of course, we'd love to see you in NYEVS for the conference. Dr. Ferries and I would love to welcome you in New York. So with that, Raman, why don't you sign off? And before you do that, Raman, one last thing I was asked by Kimberly. Really like to thank all the people who support our educational initiatives. From in this particular case, it was Medtronic who was the lead, but obviously Medtronic, BD, Philips, Abbott, Terumo. I don't want to forget everyone, but Terumo. Who am I forgetting, guys? Concept Medical, Raman, anyone I'm forgetting? Chime in anytime. But anyway, we will put that up, and we want to thank all Cajun, Phillips, everyone. Thank you very much, everyone, and we really appreciate it. Without your support, this cannot be happen, and we really, really appreciate it. Dr. Ferries, any final comments?
Absolutely no. I think well executed, and obviously another great case for your team.
Thank you again. Thank you, Christopher, and thank you, Maria. Thank you. All right, wonderful. Thanks, Raman.
All right, guys. Thanks again for joining us. This was a fantastic case of our first utilization of the Neurogard device here at Mount Sinai. This is, again, as Prakash had just mentioned, this is our final broadcast before we hope to see you all live and in person at our New York Endovascular Summit on September 11th and 12th and 13th. We are really look forward to hosting a really fantastic course for these 3 days with a dedicated fellows course as well on the 11th. So that being said, we will see each other in the beginning of September, and then again next month on the 24th for our subsequent live broadcast here from Mount Sinai Hospital. So to all, have a great day, and we look forward to seeing you soon in New York at the New York Endovascular Summit. Have a good day.